Congratulations to all of you who have hung in there with us. And I know that a lot of you have attended previous series, and we thank you for your participation. Let's go on to the next slide. So wrapping up for this series, if you attended all the sessions in the series live, you qualify for a signed certificate, and it will be mailed to you to the postal address that you provided us when you signed up. If you attended 5 of the 6 sessions live and then followed up with me, as a lot of you have, to do a makeup session, you'll also get a signed certificate. If you attended 5 sessions and have not followed up with me, but still want to get a certificate, you are going to receive an email saying, hey, we saw that you attended 5. Do you want to do a makeup for the 6th? You're not under any obligation to do so. However, if you want to, that's fine. If we don't have a correct or complete address for you, and it says email address, that should be home address, and your certificate is returned undelivered, we'll be happy to email you the signed certificate and you can print it out. But we won't be mailing if you didn't give us the correct mailing address again. And then finally, if you attended fewer than 6 sessions, you will also receive an email with a link to a survey. Fill out the short survey, and at the end, you'll have access to a self-signed certificate that you can download and print out for yourself. So as I say, we are to December 11th, the final session in this series. And if Zoom did email you and say that we're meeting next week and Christmas Eve and whatnot, that's incorrect. We're not. This is the last for this series. And we're delighted to be joined by Dr. David Tam. And this evening we have a different co-host. We have Emma Braun, who works with Christy Handley. And Emma is going to do us the honor of introducing Dr. Tam.
Good evening, everyone. I'm here to introduce Dr. David Tam. He is an MD, MBA, CPHE, and FACHE. He is the president and CEO at BB Healthcare, has education and experience as a pediatric residency at the U.S. Naval Hospital in California, pediatric neurology fellowship at the Medical College of Virginia. He is a retired Navy captain and had 24 years of service. Thank you for your service, Dr. Tam. He had a distinguished and accomplished healthcare executive. Dr. Tam joined BB in 2020 and led the organization during the COVID-19 pandemic. He is a board-certified fellow of the American College of Healthcare Executives and sits on the board of directors for the Delaware Healthcare Association and the Delaware State Chamber of Commerce. He was named CEO of the Year by the Delaware Business Times in the large nonprofit category in 2022, and one of Delaware's most influential people in healthcare by Delaware Online. So thank you so much for being here, Dr. Tam, and I will let you take it from here.
Thank you very much. And I know that Tim is going to put up my story, but let's see. I think this is in the middle, so if you can go back, that'd be great. Hi, everybody. Obviously, I can't see who's there, who's listening or who's watching, but I'm very happy to be here. And we're going to talk a little bit today about stroke, about the brain, and about the ways we treat it and how important it is to treat it timely, and also about a little bit about what happened to me. Bottom line up front, I had a stroke in March of this year. And this is sort of a journey kind of discussion. I'll put it in context as we move forward. Emma, do you want me to just say when to go to the next slide, or how do you want me to do that?
Tim is running them, but I think that will probably work out just fine.
So, I am the CEO of BB Healthcare. BB Healthcare is a local nonprofit independent community health system in Southern Delaware in Lewis. But it is more than just Lewis. It is not a hospital. It is actually two hospitals in mostly the eastern part of Sussex, but we have over 40 sites of care. That's 40 clinics, labs, pharmacy, ERs, cancer centers spread throughout southern Delaware, which, as many of you know, is one of the fastest growing counties, certainly in Delaware, but actually it's one of the fastest growing counties in America. When you look at various measures of that measure growth, for example, everything from cell phone utilization to residences, to home sales, to traffic, it is now one of the fastest growing counties in the United States, and that makes BB Healthcare a really busy place to be. It's why I came here, and I'll talk about it a little bit. But to give you context, I came here in 2020. I came here from LA. I ran the market for a large health system in the western part of the country called Providence St. Joseph's Health. And I came to Delaware because I really wanted to run my own shop. But it is going to be I hope it's fascinating to hear for you guys how the things that I decided to do, the things that I thought were important to do for this community, which is a medically underserved area. We have a lot of patients and not enough doctors and not enough clinicians and not enough access to care, that somehow the stuff that I wanted to get done in the end ended up, as you'll hear later, basically saving my life. So, when I talk later about the things that occurred and the work that we have done with places like Jefferson to create stroke care, it really is something that's unique for me in the sense that what we put into place in 2020 was exactly the stuff that ended up saving my life. And as you can see, making sure that I, have no negative consequences from the stroke. So I'll talk a little bit about stroke first. As you know, I'm a child neurologist, which is actually a neurologist trained in both adult and child neurology, who also is a pediatrician, and becomes a pediatric neurologist. So I'll tell you that we're going to talk a little bit about the brain. So as you know, the brain is the control center of the human body. It's broken up into multiple lobes. The frontal lobes and the parietal lobes do a lot of the thinking and the motor component. The frontal lobe is the part that you might have heard about, the frontal cortex, a lot of work with thinking and calculations. Parietal lobe has a lot of motor functions. You see that space between the pink and the yellow is actually a strip on the brain that really controls a lot of motion and how to coordinate your musculature. The occipital lobe towards the back of the brain on both sides is primarily directed at things like vision and the ability to coordinate vision with other parts of the body, other parts of the brain. You see the temporal lobe, that green part, which is almost like a coordinator of all the brain functions in the sense that it helps with coordination of memory and integrating inputs from different parts of the brain so that it all gets stored in sort of, if you will, a hard drive component that things get coordinated out of. The light gray part of the brain is called the cerebellum, and that's the part that sits way in the back at the bottom. If you are, interested, it's like right where your neck and sort of your skull connects. The cerebellum is mostly involved in a lot of balance and coordination functions. So that's really important in terms of how things move. And then you see the spinal cord, which takes all the tracks from the brain and takes them down the spinal cord and then processes it out to different parts of the body to control and also to receive sensory input. Now, one thing before we go to the next slide is simply that one of the things that isn't on this identified on this picture is something called the brain stem. The brainstem is right above the spinal cord, and it is the place where the spinal cord and the regular brain really connect. If you think of the spinal cord as the freeway that all the lanes connect into, the brainstem is kind of like the interchange or the bypasses, all the different ways those highways or those lanes transfer to different places to get to places like the cerebellum or the temporal lobe or the frontal lobe or the parietal lobe. This is an important part for later on when you think about then what happened to me. And I'll tell you what happened to me was I had a brainstem stroke. And that made it really confusing in a way. I'll talk about the symptoms related to stroke management. So that's the brain. All of us have it. Let's move to the next slide. By the way, I don't have the QA functions up and running. So Emma and Dr. Gibbs, how do you guys usually handle the questions? Do you want to wait till the end, or how's it work?
Yes, we'll wait until the end, please.
Okay, then I'll get off of that. The brain is fed by a very intricate network of blood vessels. So blood gets pumped up to the brain from the heart. There are two sort of sets of arteries that feed the brain. One is on the front side, the anterior side, and you can see it right there. See the internal carotids? They come up, they're right here along the neck, and they go up and feed the front parts of the brain. So they're very important. And, you know, they're the ones that you watch a bunch of SEAL team movies or terrorist movies, and those are the ones that get cut. They're very susceptible to injury. And many times those are the ones that get obstructed because they are the major highways of blood flowing to the brain. You can also see, though, that there are other parts of the blood vessel network. You see the vertebral arteries. See it on the towards the bottom of the screen. That's what we call the posterior circulation. And these vertebral arteries come up sort of in a different set of pipes feeding the back of the brain. That's the cerebellum, the brainstem, and then the back half of the brain. And between the vertebral arteries and the carotid arteries, you can see that there is a lot of redundancy, a lot of blood flowing back and forth and in circular fashion, because the brain was designed and the blood vessels were designed to make sure that if one blood vessel for some reason got damaged or occluded, then you still have all these other peripheral artery system that then can perfuse the brain from another way. That's the safety mechanism that's that nature has placed in creating this vertebral basilar internal carotid artery system to make sure that the brain continues to get blood even when there is obstruction of one of these blood vessels. So keep in mind, before we move to the next slide, the vertebral arteries and what they feed most. You can see the vertebral arteries, they come up from the back. They actually come through the vertebral arches, which is like where the spine is, and then they end up perfusing the brainstem. What you see actually where that arrow is a representation of the spinal cord moving up into the brainstem, right? You see all those little, almost like a bunch of spider legs feeding the different parts of the brainstem, and then it all connects into one big circular arch that allows blood to flow throughout the brain, even if there's damage to one part or another. Next slide, please. So there are two types of strokes, and basically a stroke is a brain attack. If you think about a heart attack being basically blood flow to a portion of the heart musculature, the cardiac musculature gets obstructed, that part of the heart dies, the heart muscle dies. And in this case, when you have obstruction of blood flow to a part of the brain will then die. There are two kinds of strokes traditionally identified. One is ischemic and the other is hemorrhagic. In an ischemic stroke, it's usually caused by a clot. As you can see, it's caused by blockage of one of the arteries, whether it's a cerebral, it's the carotid artery or on its other tributaries, or on the other end, the vertebral artery, the basilar arteries. It is probably the most common. We'll talk about the reason why it's more common than a hemorrhagic stroke. And it results in tissue death because basically when you have an obstruction of blood flow to a portion of the brain, glucose and oxygen cannot get to that portion of the brain, and the brain cells begin to die almost immediately. You might have heard of something called a mini stroke or a transient ischemic attack or a TIA, and that's when you have a clot that can temporarily block a blood flow of a blood vessel. Think of a blood vessel not just as a straw, but actually as almost like a piece of pasta, if you will. What would be a good piece? Like a ziti or something, something that has that has a hole in the middle of it. The blood vessels can constrict, can expand depending upon what's going on. And so a transient ischemic attack can be when there is a clot that occurs. It can cause the blood vessels to shrink down, cause blood flow to get reduced. But depending upon how amazing the brain is, it can also, the blood vessel can also increase in size and allow blood flow to go on, even if there is a clot. The hemorrhagic stroke, on the other hand, is usually a blood vessel that for some reason is damaged and ruptures. And when a blood vessel ruptures, it can cause bleeding into or on the brain itself. This also creates a disruption of blood flow and therefore can also create a disruption of brain function. That bleeding into the brain can also create other issues, like, for example, tissue death. It can also cause other things like terrible headaches. It can also create seizures to occur. So there are multiple things that happen. But in this case, you want to talk about how, in this case, we're talking about stroke, where blood flow doesn't get to a certain part of the brain. And by the way, you can have both. You can have an ischemic clot or a stroke that causes the blood vessel to get damaged. And that in and of itself can also then create a hemorrhagic stroke. It can occur where someone has a blockage of an artery. And if you think about it like a hose or something like that, if you block a pipe and if there's weakness at that pipe, that weakness may actually rupture, causing hemorrhage or bleeding, a leakage from that hose into other parts of the brain. Next slide. So here are the risk factors for having a stroke. Some of them are modifiable and some of them are non-modifiable. For example, some of the non-modifiable risk factors for stroke. So you can have, just because you're older, it can double with the risk of a stroke can double with each decade over 55 years of age. And so that's why you see more strokes in a lot of older patients, and certainly in a place like Sussex County, where the average age is 62, you know that there are a lot of patients who could end up with a stroke. It happens more in men, but women can also have them too. And actually, women have a higher mortality rate from having a stroke. It is more common in African Americans, and it is also more common where African Americans have a higher incidence of mortality and higher incidence of disability. Latinos and Asians, thanks a lot, also have increased risk as well in strokes. And then there's a family history is important too. Stroke, heart disease, and/or diabetes, all are predispositions for people to have a higher risk of stroke. Some of the modifiable risk factors, things that you can do to prevent having a stroke, include stopping smoking or reducing or eliminating alcohol use. Certainly using illicit drugs can cause strokes. Think about this. If you think about those blood vessels as things that can get damaged or can expand or contract, certain kinds of drugs can affect the vasculature of your entire body, but certainly in the brain can create problems where that illicit drug use can damage the brain through the damage of the blood vessels. A sedentary lifestyle is also important because it will increase your blood pressure, as you can see, and it will also increase your risk for obesity with a higher body mass index. These are all reasons why you want to be exercising, you want to be eating right, and you want to make sure that all these factors are in play because they can also help reduce your risk for things like heart disease and or diabetes. I'll talk about that in a minute. High blood pressure is also one. And the fact of the matter is, many people don't even know they have high blood pressure until they go to the doctor and they find out that their blood pressure is high. It is, there's a reason why it's called the silent killer, which is why many people don't even know they have high blood pressure until the first sign of high blood pressure is they have a stroke or they have a heart attack. Atrial fibrillation, which is a abnormal movement or rhythm of the heart, where the heart then stops moving its normal coordinated rhythm, but actually fibrillates or just shakes and contracts in an abnormal manner. And the reason why that causes a problem is because it increases the risk of having more clots that leave the heart and then go up the pipes into the brain through those blood vessels. And so atrial fibrillation, which is not an uncommon finding in patients, once again, as you get older, is also a risk factor. We call it modifiable because you can detect it, you can get it treated, and also it is something that you can actually treat through different mechanisms to prevent any clots that occur from going up into your brain, and we'll talk about that in a minute. High cholesterol is another one. LDL, or low density lipoprotein of greater than 70. LDL is the bad cholesterol, and total cholesterol of greater than 200 is also a risk factor. And here's something you don't hear all the time, but obstructive sleep apnea is also a risk factor for stroke. And for those of you who know, it's, people call it snoring. The more you snore, the more likely you have of obstructive sleep apnea. It is related to, of course, things like being overweight, having a high body mass index, but it's unclear why sleep apnea in and of itself can cause a stroke, other than the fact that it causes significant changes in your oxygen levels in your blood. And if you think about that, the oxygen levels in your blood can also impact, once again, those blood vessels and whether they constrict or expand, and can cause damage eventually over time to the blood vessels, resulting in clots and hemorrhage. Next slide. So the signs and symptoms of stroke: be fast. So keep that in mind as a good way to remember. B is talking about how people with strokes will have a balance problem. They feel like they suddenly can't keep their balance. They may feel like they're unsteady. E is for eyes, where you can have a person with video disturbances in either one or both eyes. F is for face, for the fact that many people can have a facial droop of one side or the other. Remember, we talked about how the brain is controlled along that motor strip. And if you affect that motor strip, if blood vessel is occluded on that area, you can have sudden onset of facial weakness, where someone just droops and they're drooling, and it just looks like they're totally off center. A is for arms, where actually one arm can be weaker than the other. Once again, along that same motor strip on one side, you can have an arm or leg that gets weak or gets numb. S for speech, once again, along that same strip, right, between the motor strip as well as the cortical strip. You can have speech problems where someone is speech is slurred. That is a control, the part of the brain that controls your ability to coordinate your tongue, your mouth, your throat, your larynx. Or do they have trouble speaking? Or is it not necessarily the ability to coordinate your mouth, but actually confused because that part of the brain, that memory part, can't remember the word that they're trying to say. So the phrase is called aphasia, where you can ask somebody, what is that? You're pointing to a car. They may be able to say the word car, but they're unable to even remember the word car as a representation of the thing that they're trying to say. T is not a symptom per se, but it is important because when you talk about be fast, you have to make sure that if any of these symptoms come in combination or of themselves, you must call 911. And so time is of the essence. Time is critical to save brain cells every single second. Next slide. And when someone comes into the hospital like BB for emergency room for a stroke, we do a couple things. First, we do a CAT scan, a CT scan, which is, of course, as you know, a really sophisticated X-ray of the head. And we do something called a CT angiogram of the head and neck. CT angiogram is a CT scan, and we also use a certain amount of dye to look at the blood vessels to see if there's a clot, if there's an obstruction in one of those vessels that we talked about earlier. And a CTA is done immediately when someone comes in who has symptoms of a stroke. We may or may not do an MRI. It'll be really important to do an MRI moving down the road a little bit because we want to make sure and look at the extent of the damage. But at the end of the day, the first step in the workup is a CT angiogram. We also do blood work right away because we want to make sure that when someone comes in, we want to make sure that what's their blood sugar, right? What is their cholesterol? What is their thyroid function? What is their blood clotting capability? All those factors are in play, not just to say whether it's a stroke or not diagnostically, but then as you start to move into therapeutics of what we do, you want to make sure that someone can get the medicine that they need for the stroke because they don't have anything else going on. I'll talk about that in a minute. We also make sure and get an EKG because remember we talked about atrial fibrillation. Atrial fibrillation could be going on, could be asymptomatic. A person may not feel that something's going on in their heart that's abnormal rhythm, but an EKG will show that. And we want to make sure because that's something that can be treated by medication to stop the AFib. The other thing we do, especially here at BB, but across the country in many ways, is have a consultation with, in this case, Jefferson Health Neurology, with our Jefferson teleneurology robot. So I think let's go to the next slide, Dr. Gibbs. So as you can see, this is a CT of a stroke, and this stroke is pretty well defined. Obviously, you can see the dark areas. That's already damage that's occurred to a large part of the brain, right? That, if you can, once again, on a CT, you can see that's along the frontal and parietal lobes of the brain on one side versus the other. You can see the other one where the yellow arrow points to a stroke of that brain. I'll just show also the interesting thing, if you look at that brain, one of the things that you may recognize is the fact that, you know, all of us have these sulci, which are these areas where the brain, you know, has all these little convolutions, right? They look like little wrinkles in the brain. So this middle picture shows actually wrinkles that are a little bit more pronounced, that there's more space. And this is one of experience, but I will tell you, this brain is of an older person, probably. I don't know the actual individual. And the brain has actually shrunk. Now, is that because of age? Is that because of dementia? But once again, that's a risk factor for someone who may have a stroke, because what that means is there's more room for bleeding to occur, or for some kind of hemorrhage to occur. You can see over here on the last one on the right, another acute infarct. And once again, you can see that there's some areas of the brain where there's other dark areas that show that there's been some shrinkage of the brain in the past. Now, whether or not that's due to other infarcts that may have occurred, other strokes that may have occurred that nobody picked up on, that's going to be something where an MRI may be of use down the road. But right now, you can see in all these three, clearly there was evidence of acute infarct or acute stroke. Next slide. So, someone comes into the emergency room because someone did a good job. They did be fast, and a family member or they themselves said, I better go in and get 911. And the ambulance or the paramedic came in and saw the patient and said, yeah, looks like you might have a stroke. Called the emergency room, started the process, and got them into the ER. And what we did right away here at BB Healthcare, where we don't have a lot of neurologists standing by 24/7, 365, is we instituted the stroke protocol immediately. We make sure that the patient doesn't wait in the emergency room, doesn't even go to a hospital, go to a emergency room. We go right from the ambulance directly to the CAT scan, and a CT angiogram is done. And then we start doing all that workup that you saw, the EKG, the blood work, and then we make sure that they get seen immediately by a Jefferson neuroscientist using our Jefferson teleneuroscience robot. The robot is basically a very fancy, not an iPad. The video component allows for really fine visualization of the eyes, of the face, so that a neurologist in Philadelphia can see exactly what's going on with the help of a physician or a PA here at BB Healthcare in Lewis, right? That physician, that neurologist in Philadelphia can also then look at labs that have been drawn, can look immediately at the CT angiogram to see what the CT shows, and can help make a determination of whether or not there is a stroke or not. Here's the reason why that's important. Because right now in America today, there are treatment options available that once determined by a neurologist, a patient can get medication to basically dissolve the clot. So it can eliminate or reduce the clot size, once again, then opening up the blood vessel and allowing all that blood to flow into the brain, and in many ways, reverse the damage that has occurred to the brain. The two medications are TPA, thromboplasminogen, as well as now a newer medication that's come out called TNK, tenecteplase. And those two medications are very effective. We've seen complete reversal of symptoms when they were given. They have to be given within a 4-hour window from when the symptoms occurred, when the symptoms started. And so one of the things that you will see if you ever do a rotation with us, or even at Jefferson or any place else, is a really careful history taking of when did this start? When did your symptoms begin? And the reason why that's important is because once you get past the 4-hour window, the efficacy of the medication starts to go down. At the same time, it's still a drug that helps with basically reducing clot, making things to the point where then it could create a greater risk for bleeding if you go past that 4-hour window. So people are very careful, and that's one of the reasons why in America today, it is a neurologist who has to be the one making a decision about whether or not these medications can be given. They're given IV, right? So it's not a special surgery or anything like that. Here at BB, we do a lot of those, and we end up admitting the patient here at BB in Southern Delaware. Patients recover. They're usually hospitalized for 24 to 48 hours. We make sure that we do all the other testing, right? Their EKGs to make sure that do they have AFib or some other heart rate irregularities? Do they have normal thyroid functions? Is their diabetes out of control? Is their high blood pressure out of control? And those are all things that are done at BB. We've now stopped sending patients to Jefferson if they have an uncomplicated stroke that has recovered, and we're doing very well with that. And of course, they follow up on the outpatient basis with things like physical or occupational therapy, also with their primary care physician to make sure that their diabetes or their high blood pressure or other medical problems are controlled to prevent future strokes. Now, occasionally, a patient may need to be transferred to Jefferson, and there's a couple reasons for that. Number one, if there was actually bleeding in the brain that occurred, and that bleeding causes things like swelling or damage to other parts of the brain, and they may need neurosurgical intervention to treat that swelling, then they get transferred to Jefferson. The other one might be if the clot busting drug, the TNK or the TPA, you give it, and it doesn't work. It doesn't make a difference. And when you do a follow-up CT angiogram and that clot is still there are sometimes people that just don't respond to these medications, in which case the only next level treatment is to actually take a catheter, go into the groin, and have the catheter go up the blood vessel and just go in and start looking for that blood vessel and that clot and doing something called an embolectomy or a thrombectomy and actually removing the clot that way. A third way is, if that's not possible, you could potentially do a neurosurgical procedure and get the clot that way. And so there are many reasons why a patient may be transferred. And of course, once again, the majority of the time, that transfer has to be done in a timely way. It usually requires a helicopter. BB Healthcare has worked really hard with Jefferson. Not that other places aren't better or worse or anything like that, but that way we have one partner where we have smooth transitions. We have a smooth ability to make sure that the care at one place versus the other place is well coordinated, and that we are able to work with those physicians. Don't forget, in Philadelphia, those doctors are licensed in the state of Pennsylvania. That means that they do not potentially have the ability to work even by video in Delaware unless those doctors also get another license in the state of Delaware. So for us working with Jefferson, all of our neurologists that do work by teleneurology have Delaware licenses as well as Pennsylvania medical licenses. And that way we work together to make sure that the patient care is coordinated, not just immediately with the stroke, but even later on in terms of following them up for their medical issues and medical problems. Next slide, please. So our goal when we do this is to make sure that we prevent a second brain injury from another TIA or stroke. It is really important, though, to make sure that we get patients treated as fast as possible, because the patient will recover quickly and recover their function if we can take care of that clot. The fact of the matter is there is brain damage, but if we can limit the brain damage and get that flow going to all the other parts of that brain, then we eliminate or reduce the side effects or the complications of the stroke. Remember all those blood vessels going and redundant in different places? That's the whole idea, that by getting to that one clot, we can do everything possible to get the brain blood flow as well maintained as possible. And that's why it's important for us to get treatment going as soon as possible. We also need to make sure that we educate people on individual risk factors. And then we encourage people to take control of their health. Many times people they already knew they were diabetic, but you know what? They didn't do a good job of managing their diabetes, taking their medicine, or being on insulin or anything like that. Or, I'm not having any problems. So, I'll still eat what I want and not exercise, and not worry about it. Strokes or heart attacks are sometimes the first sign. And isn't that a terrible thing that the first time you know that there's a problem is when you have something that is potentially irreversible and life-threatening. And the goal also is to return people to their prior level of function as quickly as possible. I've had airline pilots, not airplane pilots, airline pilots who had a stroke, came in, got treated, and then had full recovery of their function. And they still had to go through all the FAA clearances, but were able to get back in to the cockpit and fly. So there are differences. It's a new way. And for those of you who are of an age, like now, that may not know this, there was a time when I was going through training where you had a stroke, there was no treatment. We didn't really know what to do with the stroke. We just sat around and waited till the stroke was complete. We did treat to make sure that the diabetes and high blood pressure and everything else. But at the end of the day, you had a stroke, and yep, let's get you into physical therapy or occupational therapy and make sure you don't die. That is changed so much. And so your grandparents or even your parents may not know that time is of the essence. And there's a real opportunity to treat something as quickly as possible and avoid being in a wheelchair or not being able to, use your hands or having a problem with speech or things like that. Next slide. And of course, we talk about making sure that people are on a healthy diet, that they exercise, reduce their stress, right? If you think about stress reduction, you think, well, how does stress work? If you think about stress, you think about things like when you're stressed out, then your body is in fight or flight. You have cortisol that's being produced by your adrenal glands, and cortisol will play havoc on your blood sugar, because if your body's trying to figure out whether you're supposed to fight or run away, the first thing it does is your body says, okay, get ready to fight or run. That means you got to release blood sugar into your bloodstream, right? Make sure that you're ready to go. And that's going to cause high blood pressure. It's going to cause diabetes and other problems. Sleep is another one. If you don't get enough sleep, once again, your body is going to be in a state where it's in constant fatigue. And as a result, it is constantly, if you think about, on the lookout for, okay, where's the saber-toothed tiger coming? And I need to be on the lookout. And once again, my body has to be ready to go, fight or flight. Make sure there's plenty of blood sugar, glucose in my bloodstream, so that if I have to run, my body can do that, right? These are the reasons why you need sleep, you need to reduce your stress, and do all the things where you take control of your health. Now, I want you to kind of look at that slide for a minute, because I think the next slide is a little bit about my story. Oh, I'm sorry. There are medications that you can take either before or after your stroke, right? So if you have a history of AFib, or if you have history where your blood is easily clotting, you can be on you can take aspirin or Plavix or things like that. You can be on other anticoagulation treatments that you've heard and watched on TV, those commercials about Xarelto or Eliquis. Of course, blood pressure medications are really important to help reduce your blood pressure. There are lots of medicines out there to reduce cholesterol, like Lipitor or Crestor, and of course, diabetic medications. And, this is one that Dr. Gibbs and I were just having a conversation before we came online about new things like seglutamide or Ozempic or other medications that, is just for weight loss, or can it actually affect blood sugars, and what is the overall implications of reducing stroke moving forward. These are the things that you have to look at as we think about how to lower your risk. But as you can see, you can't just go to the drugstore and order these and get them off the shelf. These are things where you have to have a doctor prescribe these medications. And the other thing is you have to take the medications. Next slide. So now you've heard about stroke. You know a little bit about what stroke is, and you know a little bit about how stroke risk factors are important, and about how you need to get treated as fast as possible. So, so that's me. That's my office. I'm 61 years old. Yeah, 61. And I was in the Navy for 24 years, right? You can see I'm not fat. You know, look like I'm in pretty good shape. I'm a diabetic. I knew that. My dad was a diabetic for many years, but my dad didn't ever had a stroke or heart attack. My dad died of actually cancer at the age of 91. So I've been on oral medications for my diabetes. I take them. Otherwise, try and eat right, try and exercise. You see the picture in my office. It's because I am a CEO of a local nonprofit independent community health system where there aren't enough doctors and there are more people coming into the community than you can shake a stick at. And it's a little bit stressful to try and figure out how to meet the needs of the community when you are the community health system. So yes, is there stress? Do I run? I do the treadmill. I do the 20 minutes of the treadmill sometimes in the evening. But for those of you who may or may not know, being the CEO means you go to a lot of chicken dinners. You're always kind of meeting with donors or other meetings, meeting with doctors, but doctors like to meet early in the morning or late in the evening after their office. So sometimes they don't get all the exercise that I need. Sometimes I don't eat right, but I was doing fine. And then one day I woke up, this was March 8th. I know that it was March 8th because it was a Friday, sitting there at my office behind where I'm standing. And I woke up and I was super tired. But I'm tired every day. Okay, so maybe I just thank God it's a Friday. I get to maybe take a little bit of time on the weekend. And I got to work, able to drive to work, no problem. But at the same time, thank goodness I'm living here in beautiful Sussex County. It was only like a 10-minute drive to work, right? And it's not like rush hour traffic like I was in LA. Get to work, sit at my desk, typing on the computer, writing emails, sending texts, all good. And then, I feel something funny in my mouth. And of course, by the way, remember what kind of doctor I am? I'm a neurologist. So I'm actually doing a test on myself. Like, what is that? I can la, 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 the quick brown fox jumped over the silver moon or whatever. I can do all that. It just felt like my tongue was really kind of swollen. Like maybe I had eaten something funny and I had an allergic reaction. And I told myself, I'm having an allergic reaction to something I ate last night. Like I said, I was typing okay. So remember how the arm, there was no weakness of one side or the other. But what happened next was I tried to actually, as a CEO, I sign a lot of stuff. Okay, I sign a lot of documents. So I'm sitting there, signing my name on a bunch of, contracts and things. And suddenly I can't remember how to sign my name. Something I've done a million times. And there I was with my pen on the paper, and I can't remember somehow how to sign my name. But I could move my hand and I could draw other things. I drew a cat, I drew a dog, it looked fine. I drew a clock, which is something you do in a mini mental status exam. All of it came out fine, but I couldn't remember how to sign my name. And then I got up and I was getting ready to go to a meeting, and I stubbed my toe on the door jamb, and my assistant said, "Dr. Tam, you look kind of pale. Don't you think you should go to the emergency room because you just kind of stumbled?" "No, I'm okay. Yeah, I've got some stuff, but I'm tired, you know, tongue swollen. Um, Maybe I slept funny on my hand, but I'm all right." She said, "If you don't go to the emergency room, Dr. Tam, I'm going to call your wife." Right? So I said, "Okay, I'm going to the emergency room." And when I went to the emergency room, I stood at the front. I didn't go in the back. I didn't call out my buddies. I said, "Hey," I went to the registration desk. I said, "Hey, I think I'm having a stroke." And we jumped right in and performed the protocol that I described to you with every single stroke patient that we have. Within seconds, I was taken back, got my blood vital signs done. They drew my blood right away, put it in an IV, and within seconds, I was in the CT. They did a CT angiogram, and then they shifted me over to an exam room where I was, basically had all my clothes taken off. Someone examined me really quickly, and within literally 15 seconds, the Jefferson neurologist was on the Jefferson teleneuroscience computer robot, and we were talking. She examined me through the robot. She with one of the PAs helping me. She looked at my labs. She looked at the CT angiogram, which was available to her right away, and I had had a stroke. The stroke involved the brainstem. It was in the back of the brain on the left-hand side, left vertebral basilar artery. Remember, the vertebral arteries are the ones that come up the back and feed the brainstem. So that's why it didn't affect any of the actual coordination of movements or cortical thinking, right? I wasn't confused, but it did involve a little part of that parietal lobe, which is why I might have had a little trouble not coordinating my hand, but remembering how to sign my name, something I should have remembered. And here's what happened after that, and I'm going to make sure you guys hear this loud and clear. The questions that I got asked over and over again by the neurologist. When did the symptoms start? When did the symptoms start? Well, let's see. I woke up and I was tired. I came to the office and I already had some symptoms. It had been over 4 hours by the time that I was in the emergency room being evaluated. Therefore, I was not a candidate for TNK or TPA. And so what happened then was they did load me up on some other, what they call antiplatelet drugs, not clot busting drugs, but drugs that potentially will help from the clot getting worse. And then because there was a question on the angiogram about whether or not there was a blood vessel abnormality, maybe a tear in a blood vessel down here, they went ahead and airlifted me to Jefferson. Scared me half to death, scared my wife half to death, and got to Jefferson. And by then I had started to make some recovery. In fact, my wife was in DC and she came back and she met me in Philadelphia. And by then I was using my computer. Boy, did I get in trouble for that. But I'm proud to say that I've made a full recovery. I'm on a bunch of medicines now. Next slide for a minute. Let's see if the next slide is. I forget. So let's go back to the other slide, if you don't mind, Dr. Gibbs. So here's what happened. I spent 3 or 4 weeks out of work for a full recovery of all my symptoms. I did go to occupational and physical therapy to make sure that I was fully recovered. I found out that my diabetes was out of control, that I thought I had it under control, but I didn't. My blood sugar was super high. And as a result, that probably led to irritation and eventually damage to the blood vessels that were involved in the brain, as well as probably every other part of the body, right? I mean, pipes are pipes, whether it's for the heart or for the arm or for the brain. So I've also had a cardiac evaluation to make sure that everything's okay, and everything is. So I'm on a bunch of medications. I've got my cholesterol lowering medication now, that's new. Several diabetes medications, as well as, like I said, the medications to make sure that I don't clot anymore. Remember, there's a difference between the clot busting or clot dissolving drugs that you can get right when you have a stroke, as long as you're identified fast enough. And then the other kind of drug is the clot prevention drugs like Plavix, of which I am on. I will tell you that it's been a really challenging recovery, not in the sense of having to go and like have a wheelchair or something like that. And for that, I am truly blessed, but really getting to the point where I realized that I could not live the way I had lived. I now have a Whoop band. I use my Apple Watch to make sure that I sleep as much as I can, that I regulate myself. You know, to be perfectly honest, I don't do as much in terms of doing things like Facebook or things that used to stress me out a lot. And I have other people doing that because that level of stress was just too high for me to manage. I make sure that I eat regularly, that I use the right foods, that I'm watching my diabetes and my blood sugar. I'm on a glucose monitoring monitor so that I can always know exactly what my blood sugar is doing as I continue to monitor, what I eat and what the impact of it is. Now, for someone who is still active, goes to dinners, right, has to speak, go to public events, you can imagine that that's a challenge, but it is a challenge that I accept freely because the consequences of letting my diabetes or I didn't have high blood pressure, or my cholesterol get out of control is the probability that I would have another stroke. The other part is just the consequence of some of these medications. So now I'm on a medication that helps prevent clotting to occur. What does that mean? It means that I actually have to be super careful now. When I am working with sharp objects, I have to make sure that I don't cut myself because that bleeding is not going to stop unless I have to go back into the ER and maybe get a suture or something like that, right? So no more skydiving for me, right? Things like that. But there are consequences to this action. And then the last thing I'll say is the other consequence was the psychological consequence. Because you just feel, especially as you talk to your parents or even your grandparents about how this kind of thing really makes you feel like you're so vulnerable, right? It's like for many of you, hopefully in your high school years, you get in a car accident and suddenly you find out that, you know what? You can't live to be 100, that you are vulnerable and you have to be careful. These are things that weigh on you over and over and over again as you get older. And these are things that if you can imagine all the people who live in Sussex County who may have had a heart attack or a stroke or some other kind of cancer scare or things like that, that is a psychological problem that is really big and weighs heavily on people, especially when you don't have the ability, like me, thank God, to eat right, right? To go to the right markets, to go online and to get the right medications, to have health insurance, to make sure that I have a treadmill. So even when it's like 32 degrees and windy outside, I can get my 40 minutes of exercise, 20 in the morning, 20 at night. These are important factors for you to remember. Eventually, if you hopefully get to be in the healthcare field, to know that other than the simple thing about treating somebody with a CT and then making sure that they get the right medications, that there are so many different aspects of medical care that impact a patient, and that you as a healthcare professional, whether you're a doctor or a nurse or a lab tech or a physical therapist or a social worker have to include in your thinking process that is simply more than the right drug at the right time. But thank goodness for me, I've made a pretty full recovery, and I'm very grateful for that. Thank goodness that even though I waited and waited and waited and denied, I was right around the corner from an emergency room. And then I'll tell you, the thing that I really am excited the most, or the thing that I feel good about the most, was in 2020, when I got here during COVID, we didn't have neurologists to be able to cover the emergency room 24/7, 365. So I actually worked with Jefferson to institute this Jefferson Teleneuroscience Network so that any patient who comes into our ER would have access immediately to that life-threatening treatment through Jefferson Health. And isn't it kind of ironic that it's that same protocol that eventually got me and made sure that I recovered? Next slide. Now, this slide is in because I know that many of you are interested in the healthcare field. I was born and raised to be a doctor. I'm a firstborn son of a Chinese immigrant family, and it was like, okay, you're going to be a doctor. You're going to apply to medical school. Okay, and I did. But I think somewhere along the way, I might not have really thought it through or didn't know whether I was really convinced about that. So I joined the Navy and had the Navy put me through medical school in Bethesda at the Uniformed Services University of Health Sciences. I did a pediatric residency at the Naval Hospital in Oakland, California. And then I did a neurology fellowship at the Medical College of Virginia. And I was in the Navy for 24 years. Now, you might want to know, well, how a guy who did 4 years of med school, well, 4 years of college, right, pre-med, 4 years of med school, and then 3 years as a pediatric resident, and then 3 years as a neurology resident with a special focus on pediatric neurology, and then got out and practiced pediatric neurology in the Navy for many years. And by the way, you might ask, why is there pediatric neurology in the Navy? Because, you know, a Navy doctor takes care of Marine kids and Navy kids. And believe you me, the sailors and Marines know how to have kids. And it's our job to take care of them. So I served for many years as a pediatric neurologist. But what happened was, after a while, every time I tried to do something for a patient, I ended up somehow being told no, that it's not a covered benefit, that administratively it's too expensive, or that it's not necessarily protocol. And so I ended up being a nerd and reading contracts, reading policy manuals. And it turned out that many of the times those patients were eligible, should have gotten the care. But there was a kind of a discrepancy between what a doctor knows or what a nurse knows and really what an administrator knows. And it's not that administrators are evil people. You know, I know there's a lot of discussion out there, especially with what happened with Mr. Thompson with United Healthcare in New York. But the fact of the matter is, administrators are not necessarily evil people. But many times it's how doctors and clinicians communicate effectively with administrators to make sure that we do everything right for the patient. Patient advocacy doesn't just start with evaluation, diagnosis, and end with treatment. It really goes on to be how to advocate for patients to make sure that patients get the best care possible and the best coverage possible. And so I started moving into administration. I ended up becoming a commanding officer of a large teaching hospital. And then when I retired, I was the chief operating officer of TRICARE, which is a military health insurance program, for a while, then went on to work in other civilian organizations. And eventually, because I wanted to try and apply all the things that I had learned as the boss, I got to come work at BB Healthcare here in Lewis, which, as I said at the beginning, is more than just the eastern part of Sussex County, but extending further west into places like Ellendale, going south into Dagsboro, or places where I really want to make sure that we take care of people who may not have the ability to have access. So that's my healthcare journey. And that's kind of how I got into this job. And I have to tell you, like I said, figuring out sort of the administrative details and knowing things like licensure and knowing things like signing contracts and figuring out deals and getting the Jefferson system into Sussex County was a good thing for patients. And interestingly enough, turned out to be a good thing for me as a patient. So that is my journey. That is my story. And I think that's the end of the slides. And I'm happy to answer any questions that you may have. I don't know exactly how we're going to do that, but I am ready to go.
I'm going to ask them in questions we have. And look, Christy is with us now. Hello, Christy. All righty. So one of the questions, and I'm looking over to another monitor to make sure that I stay off of brand names and go more generic. How do you feel about home EKG monitors?
Let's see. How do I feel about home EKG monitors? Here's my answer to that. EKG monitors at home are great. The main question is, who is the one that is looking at the results and interpreting the results? I would say maybe even 2 years ago, 3 years ago, it would have been something where, unless it is stone cold normal, if there's any abnormality, it needs to be evaluated by a cardiologist or a trained physician, who reads EKGs on a regular basis. Because it's all about the interpretation. Why do I say 2 or 3 years ago? Because AI has made such substantial progress in the last couple of years that more and more the ability of AI to identify correctly abnormal EKGs is mirroring the abilities of a trained cardiologist. Not all the way, not all the time, but I think that it's something that is getting more and more accepted, and I'm excited to see what will happen in the next couple of years moving forward.
All righty. Switching gears dramatically. It is an unfortunate reality that Sussex County also has a high incidence prevalence, actually, of substance use disorder. Do you see any correlation between SUD and stroke in patients that present to BB?
Absolutely. There are a couple things. Number one, people who have substance abuse disorder, although I don't want to group them all together or generalize, are potentially people who may or may not have great awareness of their health conditions. And by the way, it's not just young people who abuse or have substance abuse, right? Older people do too. Older patients who may have depression or anxiety can potentially, or pain management issues can also have substance abuse. And so clearly there is an issue where someone who is abusing medication or drugs could potentially not be managing their other health conditions, diabetes, high blood pressure, and so on and so forth. Physiologically, as I said before, people who are abusing drugs also put their bodies into significant stress, right? Your heart rate goes up. Your blood pressure goes up. Your cortisol levels go up. That means that your blood glucose levels go up. All those factors play a role in increasing your risk for damaging your blood vessels, which is really, at the end of the day, what causes strokes. So both from a socioeconomic perspective about, somebody not taking care of themselves in general, and then also from a physiologic perspective, there is clearly a correlation between substance abuse and stroke incidence.
All right. Okay. Let's see. Well, there was a comment here which made me smile. Do doctors actually make terrible patients? Do they all have trouble slowing down to stop and recover?
The answer is a resounding yes. I think it's one of the things that I'm going to tell you, has been the hardest thing for me to do. I'm assuming that this group of students are Sussex County students. Is that correct?
Generally speaking, yes.
Right? So most likely you've seen me on TV or at a fire hall, or, during COVID on these things, in the newspaper. Part of my job of running a local nonprofit independent community health system is to advocate for the community health system. I mean, I was on the go. It was almost a sign of strength, right? It would have been a sign of weakness to take a break. That's just sort of how being a doctor and also how being an executive, okay, makes you go. The Navy taught me that too. The Navy used to have a phrase, um, uh, first aboard, last to debark, which meant that as the commanding officer, you're the first one to get on the ship and then you're the last one to leave. That's sort of ingrained in my head. Forget about all of the cultural stuff about me being sort of this, in this case, an immigrant, Chinese, right? Got to get the A's, got to get the A's, got to get the A's, be the smartest kid in the room. That is all stressful. And I think that as doctors, and not just doctors, but as I think a lot of healthcare professionals, we are ingrained in that. And it's almost a badge of honor to say, I worked 72 hours straight. I took care of this patient. I'm a hero. And I think that it is an important factor that as a result, doctors do make the lousiest patients. I have to tell you that I just thought that I was doing a great job managing myself until I realized I wasn't.
You heard it here, folks. Let's see. All right, so a deviously simple, complicated question. Does having a stroke increase your odds of another stroke? Do your odds increase exponentially after each stroke? And how many strokes can one feasibly survive?
Okay, so I'll try and answer that as best as I can. The data shows that if you have a stroke, there's an increased chance that you'll have another stroke. Why? Because let's face it, you've already damaged your blood. All the pipes are already damaged. Okay. Like I said, I'm 61, and that means that I spent a lifetime fully admitting to you right now, all of you, once again, I can't see you guys. I'm assuming you're of a certain age, but when I can go back right now to my pediatric residency, right? So I was at like 28, 27, and a bunch of us sitting around every day on call, eating double stuffed Oreos and Diet Mountain Dew. Don't tell me that didn't have damage going down further and further and further, staying awake all night long, right? Because that was what you're supposed to do, take care of patients. And then as a new attending, and then, trying to make something of himself, and then being in the Navy, going from place to place. So the fact of the matter is, here I am, and I know that there is damage that has occurred to my blood vessels. The angiogram didn't show any other occlusions, which is great. But, the pipes, if you can imagine pipes, my pipes probably are a little bit rustier than somebody else's. So is there an increased chance? Yes. That means I have to work really hard at taking care of myself. I will tell you the other thing is that it's kind of scary. That clot is what didn't get dissolved. So that clot is still kind of in there, right? And as long as I take my medications, that clot isn't going to get bigger. Maybe it'll get smaller because the body has this amazing mechanism to help reduce clot size and, self-repairing mechanism. But I didn't get one of those thrombectomies where there was that roto-rooter job going in and removing that clot. Think of the psychological kind of struggle that I have sometimes and thinking, wonder what's going to happen now? Wonder what's going to happen next? So it is something that can happen. You got to start early in life to keep yourself healthy and not eating the Diet Mountain Dew or the double stuffed Oreos.
Right, right. It's just like having when you've got a new car is the most important time to take care of the car, and then you continue to take care of it to keep it new. So to the person who asked about clot busting lasers, I'm going to rephrase your question. Talk to us a little bit about laser thrombolysis.
So that's a really new methodology. I know that they're doing some studies on it at an academic institution like Jefferson, but I don't believe it is right now the standard of care because of the technology necessary to have a laser that goes on the end of a catheter on a routine basis and go up. And by the way, if you think about it, there's no way to visualize the laser when it's going off in the blood vessel, right? In the blood vessel, you can see on angiogram the little kind of net or claw that goes in and removes the clot. But there is no way to look at to see the laser's impact on the clot using our current technology for imaging.
Okay, hold on for a second. I'm answering somebody's a different kind of a question. There we go. Yeah, for those of you in the webinar chat is where the survey link for you to let us know that you were here. Are the symptoms the same in young people, meaning children, teens, young adults, they have a stroke as it is in more mature adults like ourselves?
It is. The only different, I won't say it's a difference, but it is important though for everybody to recognize that Be Fast is, at the end of the day, sort of this kind of best approach structure, right? There are so many variations. I did not have almost any Be Fast symptom, right? I didn't really have a balance problem. I can tell you that when I was, I'm thinking, am I having a stroke? I can tell you that I actually did a toe to heel walk in my office. This is how much I was trying to talk myself out of having a stroke because I knew the consequences if it was a stroke, and I would do anything to say, nah, I can't be that. But I didn't have a balance problem. I could see everything clearly, right? Everything was in focus. Like I said, I had no facial droop, even though that tongue felt kind of funny, right? My arms were fine. I was doing this every hour to see if I could do that. And it was only when I couldn't sign my name and I couldn't remember, is that because my fingers were funny? Or is that and not being controlled? Or because I just couldn't remember somehow the memory of how to sign my name. But that's not really delineated in Be Fast, So I guess what I'm trying to say is those are the sort of the basics. But anytime there is a sudden or immediate change in neurologic function, call 911. It could have been, by the way, that it could have been something else. It could have been that my diabetes was actually going the other way and I was hypoglycemic. If I had really bad low blood sugar because of something, right? My blood sugar of like 40 or less, I would have many of those same symptoms. You still need treatment. You still need to be seen and treated. So it's important that whatever the, acute onset of neurologic problems, go see a healthcare professional.
Yep, absolutely. So what would your main message to the next generation of people who want to go into the medical field be? And what's your counsel to volunteers at BB who are high school students right now? Say, Dr. Tam, what do I do next?
So I started talking about this. I loved being a doctor. I really did. But although you might not believe me, because sometimes I walk around, and Dr. Gibbs knows, sometimes I walk around with my hands over my face, because the challenges are harder. When I was a doctor, 8 or 9 times out of the day, a mom or dad would usually come to me and say, thank you, Dr. Tam. Thank you, Dr. Tam, right? I'd go into the ER and somebody would be in something like status epilepticus, which is continuous seizures, not stopping. And I'd be able to basically paralyze them, anesthetize their brain, right? Stop the seizures, and then eventually get them back under control, save their lives. That was incredibly rewarding. I don't have that as an administrator now, where if I get somebody saying, thank you, Dr. Tam, once or twice a week, I'm feeling pretty good. That said, I'm doing exactly what I need to do, because the reason why I call myself Dr. Tam is because I do it all for the purpose of making sure I take care of patients. That's why I walk around. That's why I see, I see people out in the community. It's about access. It's about quality. Think about what happened with me. There are so many patients. When I got here first, Dr. Gibbs, and whoever asked the question, I had a patient. I was 2020, COVID, and I just come from Los Angeles, okay, to slower Delaware, and I had a gentleman come into my office and say that he needed help. And the help was he needed to figure out how to get his truck from Philadelphia. And I said, well, I don't think BB does that. And the reason why he said that is because his wife had had a stroke and had to be airlifted medevac to Jefferson. He drove like a bat out of hell from here. I think it was maybe Dagsboro, I don't know what, up to Philadelphia, parked in the first Jefferson parking structure there was in Center City, found his wife, but then he could not find his truck. And he had to get someone to come pick him up and bring them home. Okay, we connected the dots. We got security up there to help. That's why this stroke protocol was so important for us, because if we can keep patients close to home using the best technology possible, and the technology is there, it's many times the administrative part, making the contracts, figuring out the insurance piece, right? That gets patients what they need. And that is really something that I love to do. And so my advice to people is think about why you want to go into this. Think about what you want to do, and then make sure that you understand what your secret superpower really is. Turns out my secret superpower is to be a nerd that likes to read as many contracts and policy manuals. And also, for those of you who are older, Dr. Gibbs will know, I'm not going to say anything about Christy. I'm like the Columbo. I like being Columbo. I like the guy that knows how to solve a problem without shooting people up or, or driving a police car. That's the kind of detective I want. That's my superpower. And so for all of you out there, take the time, talk to your friends, talk to your family, because that doesn't change. And say, what do you think is my superpower? What is it that you think I like to do? And then that will be the thing that you can apply to helping people. And if it's in healthcare, there's so many things. You can be a radiation therapist, right? And be a math superhero. You can be a physical therapist or an occupational therapist and learn about biomechanics in sports, right? You can be a pathologist and work in the lab and learn about all the different chemistries. You can be a physician. You can be a nurse. There's so many different things, but it is so important for you to recognize that it's about helping people and then understanding what your superpower is, and then figuring out how to get information about how to apply that to helping people.
Right. Absolutely. So Allison asks, you say diabetes can be a risk factor for stroke. Does this include both type 1 and type 2 diabetes?
Yes.
All righty. There was another question. Right. So can an MRI show if you have had a stroke previously?
Yes.
Okay.
MRI is really good at showing previous damage. And I think the reason why I say that is because, by the way, many times, even after someone's identified as having a stroke and treated for a stroke, if there's something that's not quite right, once again, going back in the history. So you had a stroke, yes. history of headaches. Yeah, worsening headaches. Any visual problems that's been kind of, going on and on. Yeah, a little bit of that, you know. Maybe it's time to get an MRI because maybe it was not just a stroke, but maybe it was a brain tumor that pushed on a blood vessel that damaged the blood vessel that caused the stroke to occur. So the MRI is really helpful in a lot of different ways for both further diagnostics as well as potentially even more treatment opportunities.
All right. Good question. Can you talk more, since you just mentioned it, about how AI is impacting different healthcare careers?
Yeah. So AI, I mean, is getting to the point of you guys. I'm sure once again, I'm talking to a young. I don't know. You're no longer. I guess are you? Is it Gen A, or is Gen A now?
From fifth grade forward.
Right. So you guys are Gen A, right? So
I lost track.
I'm a baby boomer.
Yeah.
Okay. So here's the deal. AI is now really, it's an exciting time, I think, in healthcare. And by the way, I'm really jealous of y'all, okay? Because it's going to change. When I was an intern, just graduated from medical school, I'm at the Naval Hospital in Oakland, California. I'm now an intern, I'm now a doctor, and they walked me in. They said, come into radiology and take a look at this new thing called a CAT scan. And all of us were like, wait a minute. I'm not a veterinarian. I'm a pediatrician. CT scans were just, I mean, you were fortunate if you were a hospital and had a CAT scan. Now we've got four, two in this hospital, two in the other hospital, and a bunch out in the community. AI is going to be like that. By the time that you move into this realm, AI, for example, there's something called colonoscopies that people of our age, older age, have to have, which is a scope that goes, through your anus and into your intestines, and somebody visually looks and sees, are there polyps, are there cancers? It's usually done by a trained person who can say, that looks a little funny. I might need to take a sample of that. That looks like a real tumor, and we need to do something about that, okay? We're now at a point where there are well-accepted places where that is done by a technician, and artificial intelligence screens the images first and says, that looks abnormal, that looks abnormal, that looks abnormal, right? And if it's perfectly normal, they don't even see a gastroenterologist or a surgeon. If there's any abnormality, then they get moved to still right now a doctor to take a look. There's going to come a point where that's not necessary anymore. There's going to come a point where everybody will be, many of you have smart scales, right? Many of you may have I have a continuous glucose monitor. You can't see it. It's under my shirt sleeve. Or, you go into the Walmart or you go into the Target, and now there's these pulse oximeters where you clip on your finger and it tells you how much oxygen there is in your bloodstream. There's going to come a point where all that information will be fed into a Bluetooth device, right? And then that device will feed into a data system, electronic medical record, and AI will be the first set of systems that will identify who's got an abnormality. It won't be just, let's say it's the pulse ox. So the pulse ox shows that your blood oxygen level saturation is going down, and there's a trend. And then it ties it in with, oh, but you also have a history of congestive heart failure, or you have a history of sleep apnea, and then can alert the provider to say, Mr. Tam probably needs to get called to come into the office and make sure that he's taking his medication. Mr. Tam's blood sugar has gone up over a persistent period with a certain timeline. It's tied in with his sleep. It's tied in with his heart rate, resting heart rate. He's somebody who's at risk. We need to get him in to make sure that we tune him up. These are all things that AI can do, and that's really important because it's a way for us, especially in a place like Sussex County, where you might have trouble getting in to see your doctor or your nurse practitioner or PA, for us to be able to. That's why, by the way, BB Healthcare is commercial time is investing in a $50 million electronic medical record called Epic, because that's the way for us to harness the power of AI so that people who live way out in the hinterlands who may struggle to get to see a doctor because they may not be able to drive, they may not have a car, right? We can get them Wi-Fi, we can get them a device, and we can monitor them and their progress, especially if they're the ones that continue to come into the hospital, continue to have medical problems. That's the exciting thing about AI for me.
Right. We're almost to the end of our time here, so I want to be judicious and all right, here, I'm gonna take us down a slightly different path here. So we hear about migraine headaches, unusually bad headaches, and then we hear about ocular migraines. And so the question was, do strokes ever occur in the eyes? And I would lay the foundation that hemorrhages may appear in the eyes, but can you talk about if there's causation, correlation, what's going on there with those things that sometimes people confuse?
So first of all, let's start with optical migraine, optical strokes.
Opticals.
Okay. A stroke, once again, if you remember, is basically at the end of the day, a pipe that either bursts or gets clogged. So if you think about visual symptoms where you have some kind of change in your vision because of a stroke, it's because the part of the brain that that processes vision. Remember, the occipital lobe is the part of the brain that is affected by a stroke. It can also be, by the way, a part of the brain like the parietal lobe, because it could be that it's not the actual processing, the computer processing of the vision, but it could be that it's the muscles of the eye and how the eye is controlled. And those muscles are fed and controlled by a different part of the brain, the parietal lobe. And so it could be either one, but if they're damaged, you're going to have visual disturbances. You can also have actually a blockage of the artery that feeds the eye, the retinal artery. But technically, that's not really considered a stroke because that's just a blood clot that blocks blood flowing to the actual eyeball itself. The eyeball itself is not part of the computer that processes information. That, I hope that makes sense. There's a difference between that plus the brain part, the computer part, and all the pieces that are involved. There's even another kind of stroke that involves the, remember we talked about the parietal lobe, the lower part, where it could be not necessarily a blockage of the clot impacting the occipital lobe where the vision doesn't happen, or the part of the parietal lobe or the temporal lobe where it's controlling the eye muscles. But it could even be a part of the computer that says that what you're looking at is a dog. So you don't have the memory of a dog. So you look and it's like, what the hell is that? I kind of can see it, but I don't have an understanding. Someone says, do you see a dog? No, I don't see a dog.
Right.
So there are multiple parts of that. That's different than, by the way, a migraine. Migraines are not strokes, although there's a lot of literature coming out now about the impact, about the role of blood vessels in migraines and whether or not there's a relationship between people who have lots of migraines and whether they're at risk for stroke. But migraines are more related to the electrical conductivity. You know, every blood vessel that we have in our brain also is not just a pipe, but it's a pipe that also carries electricity. And so there's a lot of literature out there about migraines and the impact of what's going on, and is the electrical charges in the brain affecting also the blood vessels, which causes the pounding. That's still a lot of stuff is being researched right now.
Right. All righty. Well, we are at time, and I will say to you, thank you very much. You got your thank you for one of your thank yous for this week, for joining us. It's been a great session. To all of the students, thank you for joining us. You can tell it was a good session, but so many of you stuck in to the very bitter end. And I'm just going to make one final comment before we go about one of the questions that was asked about, are there recommendations or special diets that we can help to follow? Tim's wisdom says there are all sorts of things you can find on Google, but the best place to go is to talk with your primary care provider. Go there first, as they're going to understand your whole history. There are some diets out there that could have adverse effects, and it's always better to go to the experts. That said, eat smart. You know, we're coming up on the holidays. Indulge a little bit, but try not to indulge too much. And for those of you who are done with mini-med, thank you for joining us. And for students who are continuing next year, we will see you again. Dr. Tam again, thank you very much. Happy holidays, everybody.